Hello, everybody. How's it going? Good morning. Thanks for coming in on President's Day weekend to hear this talk. I'm Michael Yim. Thank you so much, Dr. Masaki, for that wonderful introduction. So as Dr. Masaki said, I am an ophthalmologist, and I am also an assistant clinical professor here. So for, I guess, financial disclosures, so I am a consultant for various medical and pharmaceutical device companies, and some of which we'll be covering here, but there's no relevant kind of financial disclosures to this talk. So a little bit about me. I was born and raised here in Hawaii. I went to Punahou, and then, as Dr. Masaki said, I came here, graduated from JABSOM, and this library looks totally different from when I was here. This did not exist. And actually, when Dr. Masaki told me I'd be lecturing in the library, I was actually really confused because I didn't realize that there was any space to lecture for probably more than over 10 people. But I went off to Miami to do my residency and fellowship for ophthalmology. Then I came back here to practice, and I practice at Queens POB1. So the objectives of our talk today is just try to get you familiar with some of the anatomy of the eye that's relevant to understanding what glaucoma is. So we'll describe the basic anatomy, talk a little bit about what glaucoma is, why does it matter to you, the treatment options of what we used to do in the past, and the new paradigm shift of what we do now more commonly in the future. And at the end, we'll do some dispelling of old wives' tales of things people told you about your eye, or things that you may have thought growing up about your eye that may or may not be true. So in general, the eye isn't as complex as one would think. You can think of the eye as just being like a camera. We have a lens in our camera, which is our natural lens. It functions just like a lens of a camera. And this is the lens that eventually develops into a cataract. And when it develops into a visually significant cataract, we can remove that cataract and get you better vision. The film of your camera, if you will, is called the retina. And so that acts just like the film in a regular camera. And the cord that connects the camera to the computer is your optic nerve. And so this is the structure that gets affected by glaucoma. And if you can imagine, doesn't matter how good your lens is, how good your retina is, if you have no cord that connects your eye to the brain, it doesn't matter, you go blind. And so that's why we care so much about the optic nerve. And so, actually, anybody want to take a shot and say what glaucoma is, if anybody knows? And there's no right answer. There's so many misconceptions about glaucoma, and there's so many different types of glaucoma. But anybody want to? Pressure in the eye. Awesome. Anybody else? So, yeah, commonly, what patients come to me every single day thinking is that glaucoma has to be elevated pressure in the eye. And what glaucoma is, and although there are glaucomas that have elevated pressure in the eye, not all glaucomas are. So what glaucoma is, it just refers to a disease that is affecting your optic nerve, or the cable that connects your eyeball to the brain, in a very specific way. That nerve that connects your eye to the brain is degenerating. And there are many different causes that make that nerve degenerate. And actually the most common type of glaucoma here that we see in Hawaii because of our Asian population is something called normal tension glaucoma, where they never had pressures that were quote unquote high. Normal pressures are 21 and under. And a lot of these people have had pressures of 14, 15, 16, and they still have a progressive optic neuropathy, which is called glaucoma. So that's the most common type here. It is not necessarily high pressure in the eye, but the treatment for all types of glaucoma, no matter what type you have, is to lower the pressure in the eye. So it's a kind of common misconception. And so why do we care about glaucoma? Glaucoma is the leading cause of irreversible blindness in the world. Over 80 million people in the world have glaucoma, and in the US, 3 million people have it. And it's often referred to by ophthalmologists and other eye doctors by the silent blindness, because most of the time, glaucoma is painless. There's one type of glaucoma that can give you an acute onset of pain called acute angle closure glaucoma, but that's way less than 1% of the glaucomas that you'll see. The vision loss that you get in glaucoma, it starts in the periphery of your vision. It affects the central vision at the very end. So all of this stuff in the periphery of your vision, you don't really see, you ignore. And because you have two eyes, if you close one eye and you close the other eye, you see kind of in your nasal aspect of your vision, you can see your nose when you close one eye very prominently, but with both eyes open, you don't see your nose when you're looking at me, right? Your brain automatically ignores those areas. So when your peripheral vision gets damaged, you don't realize that there's some big black area or shade in your vision. Your brain will project a virtual image of what it thinks should be there, so you have no idea. So, I mean, commonly every month, people come in, they have 20/20 central vision, but they could be 90% blind. And they say, you know, my doctor said I got something called glaucoma. I don't know why I'm here. I see 20/20. I see perfectly fine. And then you put your finger up. He's like, how many fingers am I holding? Like, what finger? Like, what finger? And then only when you put it in the center, they see your finger. Then that's the reason, that's like the moment they realize, like, oh my God, I can't even see anything in my periphery. But again, they don't see this whole black world. Your brain would go crazy. So your brain adapts and it puts a virtual image of what it thinks should be there. And what you pay attention to is your central vision. So who's at risk? So everybody over 50, put your hand up, right? So it's like, it's so much more common. And then, well, keep your hands up, keep your hand up. Anybody in this room also know somebody that has glaucoma or high pressure? Put your other hand up. And if you just look around how prevalent this disease becomes with the aging population. And so 50 years ago, this wasn't much of a topic, mainly because the life expectancy of people weren't that long. But people live so long these days, a lot of these chronic progressive diseases come into play more, and we see so much more of it. So there are many, many different types of glaucoma, like we were talking about before, but you do not need to know all of these types of glaucomas. The two most common that you'll hear about are primary open-angle glaucoma, and that's kind of the age-related degeneration of that optic nerve. It's kind of like when somebody gets dementia. In a certain portion of your brain, it starts to degenerate as we get older in dementia. You can think of it the same way as in glaucoma. There was something programmed genetically when you were born in that optic nerve to not have that nerve last 100+ years, but rather that nerve maybe lasts 60 or 70 years. And so when that degenerative process starts, we got to catch it early, we can treat it early, and we can slow it down. That's the name of the game for glaucoma. And so you don't need to know, again, the different types of glaucoma. That's our job. But what I hope you get away from this lecture is the basic understanding of what glaucoma is, how it can affect your vision, why it can be so dangerous, and the treatment options that are available to you, your family members, or your friends. And so for some of the key points is that glaucoma is not a disease that you can cure. Once you get it, you have it, and we can slow it down by lowering the pressures inside your eye, but there is no cure. And because it's damage to your nerve, like any other nerve damage in your body, you cannot reverse it. You can't get vision back from the glaucoma. So you got to just start slowing it down early. By diagnosing the disease early and treating it, we can hopefully slow it down so you live a long, healthy life without ever having to worry about blindness. And my job is to keep you seeing as long as humanly possible, or your ophthalmologist, whoever your eye care professional is that's taking care of your glaucoma. And every eye is unique. There are so many different types of glaucomas that each type of glaucoma responds better to certain types of treatments, both surgically and medically. And this is just a short video on kind of a cartoony video on eye anatomy relevant to the glaucoma and how fluid is made.
In the healthy eye, fluid called aqueous humor is made in the front of the eye and flows out through a tiny drain called the trabecular meshwork. The trabecular meshwork is located in an area called the drainage angle. If fluid doesn't flow out of the drainage angle properly, eye pressure increases and damages the optic nerve.
All right, and so our view of looking at your eye when you come into our office is this. So the normal optic nerve looks like this. This healthy, kind of thick donut here, this pink donut, represents the healthy nerve tissue. And the white in the center represents a dead space. So ideally, you want a thick donut, small center. when glaucoma starts to affect your nerve and it starts to eat away at your nerve tissue, you can see that thick donut here then turns really, really, really thin. And basically what's left over is this big excavated dead space in the center of your nerve. As glaucoma cupping gets worse, as you can see, this is a normal nerve here, and it becomes more cupped, and then the very thin rim of nerve tissue here, this is the corresponding vision that patient has. So the black areas represent the areas that you cannot see. So this is something called a visual field. This is totally normal. This black area is just our normal physiologic blind spot. That's where our nerve enters the eye, so we have no visual receptors there, and that's why it's black. In this nerve, about half of the superior aspect of the vision is gone and half of the inferior aspect is gone. And over here, this patient, over 90% of the vision is gone, but they have this little white area centrally. And this is the patient I was talking about earlier. This patient could see 20/20, possibly straight ahead, but if you put your finger up anywhere in the periphery of their vision, they won't be able to see that. And so this is a graphical representation of what somebody can experience in terms of how their vision loss progresses in glaucoma. It gradually tunnels in. And so luckily, we have 3 awesome ways to treat glaucoma, and usually we go from least invasive to most invasive. So the least invasive is starting medicines. We have eye drops and also oral medications, but mainly eye drops to lower the pressures inside the eye. Some are as easy as doing 1 drop at night before you go to bed. We have a lot of different types of lasers that we can do to lower the pressures inside your eye. And last but not least, we have surgery. And in general, we save surgery if medicines and lasers don't work. And so for lowering the pressures inside the eye, you can think of the eye as a sink or a toilet. We're kind of like, glaucoma specialists are like plumbers of the eye, if you will. So we can either decrease the amount of fluid that the eye makes. It's pretty simple because it's a closed system. Or we can increase the drainage of the fluid from that system. So again, either decrease the amount of fluid the eye makes or increase the drainage. And those are the targets for all of our therapies for glaucoma. So for lasers, we have a lot of different cool options. We'll talk about a selective laser trabeculoplasty, or SLT, in this talk. We don't have enough time to talk about all the different types of lasers. But in general, for this laser, what we do is we use a lens that allows us to look at your drainage system of your eye. And if the anatomy of the eye is such that we have a good view to your drainage systems, we can use a laser to, you could think of it as kind of create microperforations in the drainage system to open up your natural drains, to decrease your pressure without having to start medications. And this is a little video kind of illustrating how we do that. The laser takes about 60 seconds. We'll numb your eye with a drop here. It would be totally painless. You'll sit at a slit lamp just like you do at your eye doctor. We'll put a lens on there and we'll laser your drainage system of the eye called the trabecular meshwork, which induces changes to open up your natural drains. And that's SLT. And surgery is our last resort. If medicines and our lasers are not effective in lowering your pressures enough, then there are a lot of great surgical options, which we'll talk about now. Traditionally, especially before the 1990s, we only had 2 surgical options to treat glaucoma, and they were considered our big gun glaucoma surgeries. Those 2 surgeries were the trabeculectomy and the tube shunt. So now, especially in the advent of in 2000s, we have so many of these different minimally invasive glaucoma devices available to us, which we'll also kind of cover in a little bit. The traditional glaucoma surgery, it's not going anywhere because there's definitely a role for it. It's usually reserved for the most severe cases of glaucoma, and especially glaucoma that is trending toward having somebody go blind within their lifetime. it is the biggest risk, but also the biggest reward. You can get the very lowest pressures with these two types of procedures. So the one that you see here left is called the trabeculectomy. And what we'll do is we'll fillet open the skin of the eye around the cornea, and we'll cut down a 90% thickness scleral flap here in the wall of the eye. And we'll literally get something called a Kelly punch, which is basically a miniature hole puncher, and punch a hole in the wall of the eye to allow drainage from the inside of your eye under the skin outside of your eye to create basically another drainage system. Then we'll close everything all up, and that will be the procedure that lowers your pressure. So as you can imagine, that's a pretty darn invasive procedure. And the long-term complications from both trabeculectomies and the tube shunts, which I'll talk about next, they're potentially blinding. So anything that we can do to avoid doing these surgeries, we'll do. All we want to do for glaucoma is to buy you more time. If we can buy you 10 more years with lasers and medicines and then finally do the surgery, you'll outlive hopefully any of the complications that arise from this. Because one of the things that we do for this surgery to prevent your skin from scarring back down and closing that drainage system is we'll give some certain medications, some antifibrotics, something called mitomycin C. It'll prevent you from healing, but because it prevents you from healing, that area will thin over time. That area can erode, it can rupture, and it can cause you to go blind. For a tube shunt surgery, what we do is it's very similar in the fact that we open up the skin of the eye, and we have an implant that we sew between two of your muscles in the back portion of your eye, and then we'll thread a tube from that implant into the front portion of your eye. And that will, again, establish yet another drainage system to lower the pressures inside your eye. And again, these implants can erode over time. As we get older, our skin gets thinner everywhere, including our eye. So it can erode. The tip of this tube being in the front portion of the eye can degrade the water pump cells in the front portion of the eye, leading to possibly a corneal transplant. So anything, again, that we can do to avoid doing these until we absolutely have to, we'll do, which is why minimally invasive glaucoma surgeries are so well used now. And thankfully we have them. So this is, I rarely do this surgery anymore, but this is me doing a trabeculectomy. That's the first surgery that we talked about. So we'll put a traction suture here. That's the medicine, the antifibrotic agent that we inject. If you're squeamish, you can close your eyes. So we're doing a partial thickness cut down of the scleral wall. We try to get 90% depth. And then that's the hole punch that we were talking about. And then we'll stitch everything closed. And we have to be very careful with our stitches here to make sure that everything is watertight. Or if there's one leak, everything from the inside of the eye is going to leak outside, and you have to go back to the OR the next day. And this is, in contrast, the tube shunt, the other kind of big gun glaucoma surgery that I was talking about. This one I do more commonly. We do this every month. But we're sticking that implant between the superior rectus and the lateral rectus muscles, the top and the muscle by the ear. That's the needle tracked into the eye. And we'll put a corneal patch graft here to prevent erosions in the future. Stitch everything up. And so after, you won't be able to see the implant in somebody that's had a tube shunt or a trabeculectomy, because usually the eyelid is there covering the device. And to contrast now, the big gun glaucoma surgeries that we do, these are examples of some of the minimally invasive glaucoma devices that we have. And just so you can see how small and potentially nice to have in your eye versus something as big and invasive as a tube shunt or a trabeculectomy. Why do we do minimally invasive glaucoma surgery? It's safer. It has a much safer safety profile, lower risks of complications. It can lower the eye pressures and decrease or eliminate the need for you to possibly do the big gun glaucoma surgery. And it can mainly buy time before we have to do something more invasive. And are there different types of minimally invasive glaucoma surgeries? Absolutely. There are so many different types of minimally invasive glaucoma surgeries, and every year more devices or ways to do minimally invasive glaucoma surgery, I would say, come to market. You guys don't have to know about that, but just making sure that whoever is doing a minimally invasive glaucoma surgery on you knows exactly why they're choosing which device, and basically kind of custom fitting that for the glaucoma that you have, the rate of progression that you have, the type of pressure lowering that you need to lower the pressures in the glaucoma, because it's not a one size fit all. And especially people that are very high volume cataract surgeons that learned how to do certain types of minimally invasive glaucoma surgeries, they'll put like, it's kind of like a more of a one size fits all. Just have that conversation when you're having, when you're with them, like, why this device, and what for my glaucoma, does this device work well, and does it work well long term? So just having that conversation, being educated about that, I think is the main thing, because you do see a lot of people that when they had their cataract surgery, they had a minimally invasive glaucoma device put in, but I see a very biased patient population, because I'm a glaucoma specialist, right? So their glaucoma is advancing. They're wondering why the pressure wasn't lower, and a lot of times the device did exactly what it was supposed to do, but they may have needed something a little bit bigger or something different at that time. So just making that, before you have cataract surgery, your friends have cataract surgery, just having that discussion with your surgeon would be important. And so you don't have to know which one is right for you. Again, that's our job. So you can always, talk to your surgeon or talk to a glaucoma specialist, even if they're not the one doing your surgery. They can recommend which one is best for you based on the evidence that's out there. And it's not kind of a one size fits all. And so, because there are too many minimally invasive glaucoma surgeries to discuss, we'll go over the three of the most common ones that you guys have probably known a friend or you guys personally have had and encountered in the community. Again, these devices work on the outflow of your system. So we can affect either how much your eye makes in terms of fluid or increase the drainage system. And so what we work on for the minimally invasive glaucoma devices, for the ones that we're talking about here, we're working on this trabecular meshwork, where you can think of it as the gutter system that blocks the drains leaving your eye. And so this gutter system, just like the gutters in your house, can get clogged up with leaves and just need to be debrided over time. And we can do that minimally invasively with a lot of these devices. So this is an example of something called the Omni. And what will happen in the Omni is we'll go in here after your cataract surgery is done, or even if you don't have cataract surgery, we can do this as a standalone procedure. We'll stick a catheter behind the trabecular meshwork, which is the gutter system, and cannulate this thing called Schlemm's canal. This is a potential space that leads to the drainage systems. And when we remove the device, it shoves out this substance called viscoelastic that dilates the pipes leading away from your eyes, which is your microvasculature. And then we'll reinsert the device, and we'll rip out as much as 90 degrees, 180 degrees, 270 degrees, or 360 degrees of that trabecular meshwork, of that gutter system, depending on the pressure lowering goals for that patient. So not only do we dilate the pipes leading away from the eye, but we'll also remove that gutter system. And again, certain glaucomas are really, really, really responsive to that, and certain ones are not. So this is, and I didn't show a video of the iStent inject, but this is me doing surgery, doing the Omni device in real time on an eye. And then after the Omni is done, I'll do and insert a device called the iStent inject. And so what this device does, it's super small. It's actually the smallest implantable device in a human body, but it goes through the trabecular meshwork and establishes basically a channel for fluid to leave the anterior chamber or the inside of your eye and go straight to the collector channels or the pipes leading away from your eye. So it kind of bypasses the gutter system. So the cataract surgery is already done here, and I'll use a special device so I can see the drainage system, and I'll enter the Omni device behind the trabecular meshwork, and as I'm pulling it back, it dilates the pipes leading away from the eye. I did the inferior 180 degrees, and now I'll do the superior 180 degrees. And then I will reinsert the device and remove 90 degrees of this person's drainage system. And then after, I'll get the iStent inject. And it's like playing a video game. It's actually really cool. You point and you click a button and it shoots out. And so those are the devices. And that takes like 45 seconds. It's pretty fast. And that was played in real time, so it's very different from the big gun glaucoma surgeries that I just showed you. So this is another device called the Hydrus. It's much bigger than the iStent inject. It spans 90 degrees of the trabecular meshwork. So it'll stent open that gutter system for a whole 90 degrees. As you can see, it's much larger than that iStent. But because it's much larger, you can get a better pressure lowering profile. And this is a combination of doing both the Omni and that Hydrus that you just saw. So again, for the Omni, going in behind the trabecular meshwork to cannulate the inferior 180 degrees of the drainage system. And again, as I retract the device, it shoots out that jelly to dilate the pipes leading away from the eye. And then I'll do the superior 180 degrees. And then for this one, I think I rip out 180 degrees superiorly for their what we call trabeculotomy. And then after that's done, it's now this potential space is nice and open, and it makes it really easy to do this Hydrus procedure as well, to stent open long-term the inferior 90 degrees of that person's drainage system. And so in summary, there are many, many different minimally invasive glaucoma surgeries or regular glaucoma surgeries or treatment options for glaucoma available to you. These devices can be used for mild, moderate, and all the way to severe glaucoma. And it doesn't have to only be used in conjunction with cataract surgery. They can be used as standalone procedures as well. It is 100% not one size fits all. There are some glaucomas that they can be actually really potentially harmful in. So knowing your eye doctor will know which glaucoma to use a specific device in. And although minimally invasive glaucoma surgeries are safer than traditional glaucoma surgeries, not all people are candidates for them. So it depends on so many different factors, the main factor being whether or not that drainage system is open or closed. With time, with inflammation in the eye, with trauma, with different things that can happen in the eye, the iris or the colored portion of the eye can be plastered up against their drainage system. That's called angle closure glaucoma. In people that have angle closure glaucoma, unfortunately, because we don't have access to that space, we cannot do these types of minimally invasive glaucoma surgeries. There are other types that can be used in that, but not the ones that we went over today. And so minimally invasive glaucoma surgeries, although sometimes are not as effective in lowering getting super low pressures like a trabeculectomy or a tube shunt, it can delay or possibly avoid having to do those big gun surgeries, and any amount of time that we can buy for the patient hopefully is enough time that they can live a long, healthy life without ever having to worry about blindness or getting one of those big time surgeries. Kind of key point summaries for this talk on glaucoma is that, again, glaucoma is not something that you can cure. It's a chronic, progressive disease that can worsen over time, but most won't go blind in their lifetime. The main thing, and I'll stress, the main thing is just diagnosing it early, treating it early so you can slow it down. If you have a nerve that's 99% healthy and then you diagnose glaucoma and you start slowing it down then, you have so much more time with vision versus the patient that shows up with 10% of their vision, getting diagnosed with glaucoma for the first time, 90% of the nerve is dead. You can extend the life of that 10% remaining nerve, but it's not going to be for as long as if there was 99%, you know what I mean? There are many great options in treating your glaucoma, medicines, lasers, and surgeries, and every eye is unique. So lastly, we'll dispel some old wives' tales. So if you guys can like answer. Sitting too close to the TV. So my mom actually told me this when I was young. Sitting too close to the TV will ruin your eyes. True or false? False, yes. Good job. Your vision will get worse if you read in the dark. False. All right. Yes. Good job. Wearing glasses makes your eyes dependent on them. I actually get this often in my clinic. True, false? False. Yeah. You're just getting used to seeing more clearly. And so wearing glasses with the wrong prescription will ruin your eyes, and as adults. So I do have a caveat because this answer is different for children versus adults. So the answer to this is false. As a child, and for anybody that has kids or grandkids or nieces and nephews, it is super important for them to get their vision corrected and have both eyes with good vision. Under the age of 12, if one eye is not seeing well, your brain will learn to strengthen the good eye and ignore the bad eye. That's called amblyopia. So after 12, there's no more neurologic development to that eye, so it won't develop correctly. So forever, for the rest of their life, they won't be able to see well in that eye. So anybody that you see that's kind of cross-eyed as well, especially kids, they'll be like this, but they won't complain of double vision. They're just going to suppress the image for the eye that's crossed, and they're going to pick one. The brain will pick one eye that's dominant, and for them to not go crazy, basically they ignore the image of that one, the eye that's crossed. So that not only goes for cross-eyed, but people that have the wrong prescription. And your pediatrician or your nieces or nephews or grandkids' pediatricians should be screening their eyes every year, I think starting the age of like 2 or 3. I think they'll shoot something called an autorefractor. Astigmatism is actually one of the biggest causes of amblyopia in kids. And what astigmatism is basically the front of your eye, called the cornea, should be shaped like a baseball or a basketball, nice and spherical. And when it's nice and spherical, it focuses light onto one point and you get a clear image. With astigmatism, the eye is shaped like a football and not like a baseball. And so that distorts the light coming in, and that can be very amblyogenic or causing a lazy eye. So just having everybody get checked is pretty important. And if it's caught early, you can patch the eye. You patch the good eye, and you force that bad eye to work, and you can strengthen that eye. And so they don't have to have that visual deficit for the rest of their life. And so, true or false? Also told to me by my mother, but she wasn't wrong, but eating carrots will make your eyesight better. So to a point, right, if you're vitamin A deficient, carrots have vitamin A. If you're vitamin A deficient, absolutely, you can have damage to your eyes. You can have damage to your brain as well. But too much vitamin A, because vitamin A is actually a fat-soluble vitamin, can actually be harmful. So you don't have to eat more carrots. The average American diet has enough vitamin A in it. And so that concludes my talk. And I want to say thank you so much to Dr. Masaki, JABSOM, and then my parents for everything that they did and all the sacrifices that they made for me to even be here, paying for my education and just making sure that everything, went well. So thank you. Stand up. Thank you. Yeah, no, stand up. No, but, I seriously, though, I can't tell you how thankful I am for all the things that you guys have sacrificed in your life. So thank you. Any questions? Yes.
Thank you. I'm going to carry the mic around.
I'm sorry. Okay,
yeah.
sorry.
First of all, thank you, Mike.
Yeah.
A wonderful talk. Some scary pictures,
Oh, yeah.
right? Let's all get our eyes checked. on
Yeah.
a regular basis so that we don't have to do the major surgeries. Okay, question over here.
The first part of my response is what you just said. Thank you for a fantastic presentation. I noticed that a lot of young people now, and some that are older, get these sort of like contact lenses to change the color of their eye.
Oh, yeah.
And I would think that could be very destructive. Because you might be putting germs with that thing on the cover of your lens. What, you give your comments on that?
Yeah, so that's a good question. So I think you're asking one question, but because you asked a question on that topic, I'll kind of go into two answers for that. So I think what he was asking was basically colored contact lenses that they don't necessarily change the color of your eye, but on the piece of plastic that goes onto your eye, there's a painted iris of a different color. So blue, hazel, gray, you can pick whatever color you want. So in general, contact lenses, as long as they're used well and hygienically, you're not overusing them, you're taking good care of them, they're pretty safe for the eye. Adding the color aspect onto that contact lens doesn't change its danger profile, so it's safe to use as long as the patient's not sleeping with their contact lens, they're not doing risky activities with their contact lenses like going swimming and opening their eyes in pools. That can pick up a lot of bacteria, mainly something called acanthamoeba or Pseudomonas that we do not want. It's one of the most common causes of contact lens-related ulcers inside the eye, and that could be potentially vision-threatening, but having good hygiene is good. So for the colored contacts, okay, as long as good hygiene. The second point that kind of like a PSA thing that want to make sure that everybody knows, so if you go to other countries, there's advertisements to change your eye color. So people that have brown eyes, they say, hey, we can do a laser that can make you have blue eyes. And so, has anybody heard of this? Okay, good, because it's illegal in the US. So if you have, let me know. So I trained in Miami, and so we get people from all over the world flying in, and we're such a hub for South America too. But basically what they do in this procedure is they get a laser and they laser your iris. So they ablate all of the tissue to get rid of the brown pigment. And so they don't make your eye color blue. Actually, people that have blue eyes, they don't actually have blue eyes. It's just a wavelength of light that is reflected from your iris. The resulting color is blue. And so what they'll do is they'll erase the pigment of your iris, and the resulting color can be lighter. Sometimes they get blue, sometimes they get some other variation of that wavelength of light. But all of that pigment is liberated, and it has to drain somewhere, and it drains into the gutter system that we were talking about, the trabecular meshwork. Many of those patients go blind. They get something called pigmentary glaucoma, and they go blind. And so when it was like a really hot thing when I was in residency. So unfortunately, we saw so many blind people, and they're young kids. They wanted to look better, and so they got this procedure in Honduras, all of these third world countries, and paid thousands of dollars, and then they ended up going blind. So if you guys ever hear about that, that's not recommended, not legal. So that's a bad way to change the eye color. Yeah, the contact lens is approved.
Hi, thank you for your discussion. I've been diagnosed with glaucoma, so I'm taking eye drops every night.
Yeah.
Does glaucoma affect both eyes equally, or one eye or the other? Or
It's a great question. So do you know what type of glaucoma you're diagnosed with?
no?
Okay. Okay, so
I'll ask my ophthalmologist.
yeah, so it depends. Chances are you have a variation or a type of something called primary open-angle glaucoma, which is the kind of the wear and tear of the optic nerve, most common type of glaucoma. In that type of glaucoma, both eyes are usually affected. Over 90% of people, if they get primary open-angle glaucoma, both eyes will be affected. But what happens is that one eye gets affected first. So you can think of it as you have arthritis in your knees, right? Say you need a knee replacement in your right knee. Because you have arthritis in your left knee, just because you don't need a knee replacement in your left knee doesn't mean that it's not happening in your left knee, right? It presents your right and your left eye although they were genetically the same when you were born, they lived totally separate lives for X amount of years, right? And they're subject to different stresses, rubbing your eyes, maybe one had trauma. And so they'll degenerate at different rates. In general, they tend to show progression for the most part about at the same time, but one eye always gets worse first. So in general, for most, so depending on the type of glaucoma, if somebody has primary open-angle glaucoma and they're showing progression in one eye and they're high risk for the other eye, I'll treat both eyes because there's no downside to that. And especially for you're saying you take your drop at night. So the nighttime drop that you're talking about is likely a prostaglandin, has a little green top. Yeah, it's called latanoprost. So latanoprost is a very effective and safe medication in lowering the pressures in your eye. It also has certain cosmetic side effects that long-term can look weird, especially if you're doing it in one eye. So one of the side effects is that you have longer eyelash growth. So actually a lot of women love to take that product. So Latisse is actually a variant of this latanoprost. That's how they discovered Latisse. It was from people that had glaucoma. It's not, but if you have one eye that has super bushy long eyelashes and the other eye does not, I mean, that's kind of weird, right? The second thing is that long-term, you can get something called orbital fat atrophy. So the fat around here can get a little bit less. And so one eye can appear more sunken in the other eye. As we age too, we get orbital fat atrophy anyway, but it can definitely accelerate that and make the eyes feel very asymmetric. So in general, for a cosmesis purposes a decision as well, we usually treat both eyes, but we're giving protection to the eye that doesn't have actual progressive nerve atrophy, but we know that 90% chance that 5 years down the road, it will show it. So if we can start delaying that process even earlier, why not, right? Mm-hmm. Is it pretty? Actually, no. Yeah, heterochromia is actually pretty rare. Do you have it? Oh, nice. You're probably the only one in the room. Anybody else have two different eye colors? No? That's pretty cool. Yeah. There are secondary causes of heterochromia too. So if you've had certain diseases that affect your eye, especially inflammation, the herpes zoster virus or the varicella zoster virus can affect your eye when you're an infant and sometimes in utero, and that can lead to heterochromia, but some people are just born with it genetically. Cool.
Excuse me. I wanted to know, my sister-in-law was going to the eye doctor regularly, and they said she's fine. And then all of a sudden they said, you lost 90% of your vision from glaucoma. The silent type of glaucoma, how do you diagnose it? Because a lot of these people have gone blind before they know that they have glaucoma.
Yeah, so unfortunately I see that every month. So
Sorry.
I don't like the PC way to answer this, but in general, so it's awesome that you guys all took the initiative to come here to learn more about your eyes, and now you guys are armed with kind of this background information. I would say that there are some people that are not as comfortable looking at the optic nerve or evaluating the optic nerve or seeing or noticing subtle changes. Maybe they're just seeing 60 plus patients a day. They're just trying to get through. Sometimes that portions of the exam can be missed, right? Also, it depends on, I would say, if they're not paying close attention to the optic nerve, it is a very easy thing to overlook, because when the patient comes in, you say, hey, how you doing? My vision is fine, I'm doing okay, their pressures are okay, especially here in Hawaii, if you're Asian and you have normal tension glaucoma, those types of usual red flags don't get triggered. And if they don't look specifically at your optic nerve, they can miss it. And people miss it all the time, not only here, but across the nation. And that's one of the huge issues. So, if there are good ophthalmologists, there are some not good, and same like with optometrists. They're really good, thorough optometrists, and there's some that are not. It's not necessarily an optometrist or ophthalmologist thing. Just making sure that your eye doctor is looking at certain types of things, like look at your macula for macular degeneration, look at your optic nerve. So one of the things that you guys can do, and you guys can tell your friends to do, is just have that conversation with your eye doctor. After they dilate your eye, everybody should be getting a dilated eye exam every single year. Everybody should have their macula looked at every single year, their nerve looked at every single year. And you can ask your doctor, what does my nerve look like? What is my pressures? What does my macula look like? And so if they're uncomfortable answering that question, that's kind of a red flag, you know what I mean? But yeah, I mean, you're right. Unfortunately, I see a lot of people every single month with that same thing. And that's the question. It's like, why was I just diagnosed? This is a chronic disease that progresses over decades. Why now I'm 90% blind and I had no idea, right? So there's not a good answer to that, but sometimes it's just, you guys now have the power to ask to make sure that that doesn't happen to you.
Okay, so I've asked, and I know that I have large cups, and I don't have glaucoma, and the optic nerves and all that stuff, but I've been told that my gutter system is really messed up. This is the tear ducts, the tear ducts, and so I've been hesitant to do anything about it, except put eye drops in. I have dry eyes, but you said, like 90% clogged up and all this stuff. So now I'm wondering whether I should have this kind of thing, the laser.
Oh, yeah, so different. So great question.
Is that the same gutter system you're talking
Different
about?
gutter systems.
Okay,
yeah,
it's a
so different gutter systems. So we got two different gutter systems.
Okay, this is
the
a
one
tear
that
duct.
I'm talking about is inside your eyeball, totally unrelated to your tears. So the fluid, your eye will constantly make fluid, and that fluid has sugars, it has nutrients to keep your eye healthy over the course of its life. Because it's constantly making this fluid that nourishes your eye, it constantly has to drain that fluid. None of that reaches the surface of your eye, which is the problem.
Okay, the one that...
Correct. If you're having a lot of tearing,
Yeah.
then that is due to the drainage systems in your
this-
eyelids
right.
called the
And
nasolacrimal
it's
duct.
all blocked up. You're saying it's like it's
Yeah.
like a sink that doesn't drain well. That
Yep,
kind of-
yep.
that
But
kind of-
different sink,
Okay,
more
different-
outside sink, yeah.
Oh, okay,
Yeah.
okay. So I was
Easier
just
to
wa-
work on sink.
So I was just wondering, though, does the laser thing...
Cannot, yeah.
Okay.
So
Okay.
there are different options for that. So you can, so I would recommend going to an oculoplastic surgeon.
I did.
Oh, okay, perfect. Do you
didn't
mind
like
asking
him, though,
the name
so-
of the oculoplastic surgeon?
So anyway, I didn't like him, but he was
Okay.
saying...
We could talk after. I have some
Okay.
two that are really awesome here that would be worth looking at. Okay, yep. Or anybody?
My question has to do with when you should have cataract surgery.
Oh yeah.
Now I've heard from some people that, or the doctor has told her that she can't have it until it's ripened or it's not ripened enough. And then other people want to get it done right away. Other doctors want to have it done right away. Can you clear that up?
Yeah, absolutely. Again, that's another like PC question. So in general, the answer for when somebody needs cataract surgery, there's kind of twofold. So one, if it's impacting activities of daily living of that patient, so say you come in and say, hey, I can't drive anymore. Like I still see pretty decent, but I can't night drive, or when I'm reading at home, the lights are too dim. I can't read. I can't function in X, Y, or Z aspect of my life. And if it's due to the cataracts, then absolutely, it's time for us to take out your cataract regardless of your vision, even if you're 20/20. Because cataracts, what they do as they get worse is they scatter the light inside your eye. You can think of it as like a light diffuser. So the more aberrant rays of light, so if you're out in the noon sun, light is beaming at you from so many different areas that all gets scattered with the cataract, and that's why you can't see. Same like at night, when you're at night, your pupil dilates to let more light in, and so it exposes more of the cataract, and so pinpoint rays of light, like the oncoming car headlights, will get scattered, and that's why you can't see at night. So that's a symptom called glare, so it's unrelated to the actual visual acuity. So somebody can see 20/20 during like a kind of a low light setting like this, but they go outside, they can be 2100, they can be near legally blind. And so we test that, and if the glare is a lot, and that's the main type of symptoms, we'll take your cataract out. In general, if you have good vision, I'll just say this, for whoever your ophthalmologist is, if you have good vision and you're not bothered with your vision, you do not need cataract surgery. unless there's something like a legitimate risk to your eye. So say the cataract is getting so big that it's going to block the drainage system in your eye. In general, that only happens to hyperopic patients, so people that are farsighted. People that are farsighted, your eye is smaller than the normal eye. So because everything is smaller, everything's cramped in there. And as the cataract gets bigger as you get older, the eye is not getting bigger, it's already small. So it can block off the drainage systems that we were talking about. And that's something called acute angle closure glaucoma. And that's primarily a condition that can be avoided by just taking your cataract surgery out before that. But if you're myopic or you're nearsighted, so without glasses you see well up close, a very rare chance of you ever to go into acute angle closure glaucoma. Likely the drainage won't be impacted by that. So I would say if somebody is pushing cataract surgery on you or somebody else, definitely ask them why. You can push back, because although cataract surgery, I mean, it's a phenomenal surgery. It takes us less than 10 minutes to do it. There's no pain. The recovery time is super fast. We can get you awesome vision. But if you don't need to do it, nothing's better than your natural lens. So your natural lens has built in something called accommodation. You can flex the muscles inside your eye, and your lens can dynamically adapt, right? So under 40, most of you guys didn't have to have like bifocals or anything like that, right? Because you could flex the power of your lens to dynamically change the range of your vision. And so after cataract surgery, you get zero of that. And there are different types of lenses that we can put inside your eye to extend the range of your vision. But again, nothing's better than your natural lens. So I would say be wary of that. A lot of the most unhappy patients after cataract surgery are patients that were told that they had to have the cataract surgery done too early. And they took their lens out, they already had good vision. And you see this all the time. You see patients that were 20/20, they were told by their doctor they had to have cataract surgery. They have their cataract surgery and they come and say, why? Like, I see worse now than I did before. My range of vision now sucks. You see that all the time. And so there are a lot of people that tend to take it earlier than normal, but I would say don't do it unless you're ready and you're actually bothered by your vision.
I do want to say one thing before we have our next question. Dr. Yim has kindly agreed to come back next year to talk about cataracts.
Oh yeah, so yeah.
So just hold some of your cataract questions until next year.
Percentage of corticosteroid users get glaucoma?
So that's a great question. I don't think that's so I think the correct response to that question is what % of people that are on corticosteroids will get an elevation in pressure, right? So again, glaucoma is the actual degeneration of your optic nerve, so there's a difference. So what you bring up is a really good point. People that are on corticosteroids, like prednisone, for example, they are at risk of getting elevated pressures in their eye because those steroids, they accumulate in the drainage system, in the gutter system. They block it like leaves in the gutter, and it can raise the pressure, and it's 10%. 10% of people that have chronic steroid use, and this is like over a month type of steroid use, and certain steroids are considered dirty steroids, and some are more clean steroids. They can vary in how much they raise your pressure. And in general, somebody that has glaucoma has a higher than 10% risk to get a steroid response. So I guess the answer would be for everybody using corticosteroids, you have a 10% risk. If you have glaucoma and you're on steroids, your risk of having an elevated pressure while on steroids is way higher than 10%. So you have to be monitored by your eye doctor while you're on the steroids, and hopefully it's not on for too long.
I have a question. It's two parts. I had cataract surgery, and immediately I could see better than I did when I was in my teens.
Sure.
But now, because I go and have regular exams with my
Sure.
ophthalmologist, but now my eyesight is not what it was when I first had is that common? And the next question, this is a simple question.
Yeah.
How do you feel about your opinion about, I call them the dollar store glasses,
Oh, yeah.
which
Like
most-
over the counter
Yeah.
250s or something. Okay.
which most of us will go and get.
Sure.
My
So,
ophthalmologist, and I sort of felt a little uncomfortable with it,
sure.
he examined my eyes. I said, well, do I need eyeglasses? And he says to me, well, do you want to wear them? I said, no one wants to wear them.
Sure.
He said, well, just go to the dollar store and try them.
So,
What's your opinion on that?
So, yeah, those are all really great questions for the cataract talk, but I will answer that. So, in general, your eyes change as you get older, right? Just like other parts of your body. So the vision that you have, it can change, and it can be for a various number of reasons. Sometimes there could be macular degeneration, sometimes it could be glaucoma, sometimes there could be changing astigmatism on the front portion of your eye. Sometimes there can be a scar tissue that forms on that lens after the cataract surgery is done, and that's something called posterior capsular opacification. And that's an easy fix. We can just do a 30-second laser. There's no pain. We can clean that lens after. There's so many different reasons why your vision can change after the cataract surgery. I'd have to examine your eye. So the fact that you said that you had better vision the day after cataract surgery than you had as a teenager, likely there was kind of one or two scenarios of your previous vision. So it's all based on a lot of the patient's perception of their improvement or dissatisfaction with their vision after cataract surgery is based on their vision before. Some people are very farsighted. So farsighted people, when they were born, or I guess as a teenager, usually they could see pretty well in the distance, and they can see actually like the fly on the wall more so than any kind of myopic or nearsighted person, just because of the optics of their eye. But as they reach their late 30s and 40s, their eye is no longer able to flex to see well with that farsightedness, and their vision kind of sucks in the distance and up close. It gets worse as it comes closer. Farsighted people, especially if you're over +1 or +150, they're the happiest people after cataract surgery because their vision sucked. I mean, at all distances without glasses before that. They've never had what you could give them by putting that natural prescription inside their eye to have zero prescription at distance. People that are very nearsighted, like me, I get up, I can't see anything. Like, I can't see if you guys are a guy or a girl. I'm so nearsighted, right? My vision sucked since I was a little kid, too. So after cataract surgery, I'm going to be super happy, even if my cataract surgery results are off by a little bit, because it's just so much astronomically better than what I've ever had. There are different types of lenses. So you're talking about reading glasses and that kind of stuff. The fact that your eye doctor told you to do the reading glasses, I'm just surmising that you didn't have a multifocal lens in. You just had a lens that allowed you to have good distance vision. Is that correct? Don't even know the lens? That's okay. So in one of the most common lenses, especially in farsighted people that value distance vision, will correct them to have no prescription at distance. You can drive without glasses, you can watch TV, you can watch this lecture without glasses, but okay. So, but up close is going to be blurry. So in a monofocal lens, you can pick one distance. You can go in the distance, you can go intermediate, you can go up close, and you can mix and match eyes. You can get something called monovision, like what my dad has. See good in the distance in one eye and see up close for the other eye, and possibly avoid the need for glasses. So what do I think about over-the-counter glasses? It's good for certain people, but not so good for other people. And especially depends on the shape of your eye. If there's residual astigmatism in your eye, over-the-counter glasses won't help, because over-the-counter glasses do not correct for astigmatism. You'll need kind of a custom reader, if you will, that has that correction built in for you.
So is low pressure, low tension glaucoma more common here in Hawaii?
Yeah.
And what is the treatment for it?
Treatment for all, that's a good question. So the treatment for all types of glaucomas are to lower the pressures. So even if you have a low pressure, we got to lower it even more. So normal tension glaucoma is a super difficult glaucoma to treat because you already have baseline pressures that are super low. It's super, I don't want to say super easy, but it's way easier to treat somebody that comes in with a pressure of 30 and get them under 20 than it is to get somebody with a pressure of 12 and get them down to 7 or 8. And the reason why is because the pipes that drain your eyes, they have a resting pressure in it, right? There's blood inside those pipes, those blood vessels leading away from your eye. That's called the episcleral venous pressure. That pressure is anywhere from 7 to 11 in people. Some people with normal tension glaucoma, they come to you with a pressure of 12 or 13. So they're right on the border of having the lowest possible pressure. Up until 2 years ago, there were no medications that affected that episcleral venous pressure. So you would have to do a trabeculectomy. You'd have to do something surgical. Now we have drops that can, or one single drop that can lower that to get somebody from 12 or 13 all the way down to 10 or 9 or 8. But before that, you pretty much had to go for a trabeculectomy, which was not ideal. But that's a good question. Yeah.
I see so many other hands up, but I'm so sorry, everyone. We're out of time.
Oh, yeah, sorry.
Michael, thank you so much. Please give him a hand.